Hello everyone, I am Dr. Guillaume Grzych from Lille University Hospital, and in the second part of the video about clinical chemistry in NAFLD, we can discuss about the specific biomarker in hepatic steatosis and NASH. As we see in the first part of the video, the use of biomarker, it could be very interesting for the diagnosis and the follow-up of this whole stage of NAFLD. There are many stages in NAFLD, the simple steatosis, the NASH, the fibrosis. And this is part of the video we focus on simple steatosis and in NASH. There are many markers possible in this pathology in NAFLD. I focus on the most used combination of markers. For the simple steatosis, firstly, I focus on the fatty liver index, the Hepatic Steatosis Index, and the SteatoTest, because it's important to make the screening of simple steatosis, maybe to know what population could be at risk to develop NASH after that. NAFLD, as we say in the fourth part, is very increasing worldwide. The simple steatosis consider around 30–40% of the global population. So it's very important to screen that with biology, with clinical chemistry. Before talking about the marker, we need to know globally the pathophysiology of NAFLD to be able to choose a good marker. In good knowledge about pathophysiology, you could imagine the good marker. In case of hepatic steatosis, what is hepatic steatosis? Steatic hepatosis is an accumulation of fatty acid and especially triglycerides in the liver. The triglyceride can come from here, the liver from fatty acid, can come from the gut, from nutrition, alimentation. When you put a lot of fatty acid, you could have a lot of triglyceride in your liver. The triglyceride can come from also by adipose tissue in adipocytes. So when you have a lot of adipocytes, this increases the lipolysis. In the case of lipolysis, you release fatty acid. The fatty acid came into the liver and with chemical process is converted to triglycerides. So you have an increase of triglycerides in the liver and accumulation of triglycerides. This process is increased with obesity. When you have obesity, you have a lot of adipose cells, so you have a lot of risk to have increased lipolysis and a lot of triglycerides in the livers. You have also another component is the insulin resistance with diabetes, for example. In case of insulin resistance and diabetes, you have an increase of adipose cells and major of lipolysis and accumulation of triglycerides. And insulin resistance, also, you have also increase of lipogenesis, hepatic lipogenesis. So you make a lot of fatty acid in the livers. And you have also a decrease of beta oxidation. Beta oxidation is normally used fatty acid to make energy. And here, with insulin resistance, you have a decrease of use of fatty acid in the liver. So all fatty acid is converted to triglycerides. So you have a lot of accumulation in triglycerides in the liver. And when you have this accumulation of triglycerides in the liver, is increased also the insulin resistance. So it's like a vicious circle here. You have an accumulation of triglycerides. So for our biomarker, it's important in steatosis hepatic to take into account triglycerides, the obesity. So the marker is not biologic, but is a BMI, and also insulin resistance with, for example, glycemia or Mayer of the states of patients in type 2 diabetes. So we focus on some combination of scores using this kind of metabolic parameters. The first score used is a SteatoTest. SteatoTest is a test proposed by the Society Biopredictive. So when you want to use SteatoTest, you have first to perform the analytical measurement. And after that, you put the results of the analytical measurement into a software to get the result of the SteatoTest. And you need to pay to have the result of the SteatoTest. So first, you have to measure here some markers, hepatic markers, and also gamma GT, total bilirubin, alpha-2 macroglobulin, apolipoprotein A1, haptoglobin, glucose, triglyceride, and cholesterol. You need also to know the age and sex of the patient is used in the combination in biopredictive. Biopredictive, when you put all this data, it's able to calculate many scores. The SteatoTest, we see for now, and also the NASH test and the fibro test used for NASH and fibros. We could discuss after that about the other, but for now, for SteatoTest, is the same parameters used. You have to put all the parameters and then could calculate all different scores. The scores, the calculation is kept secret by biopredictive, so I cannot give you the score for now. So you have to pay to make the calculation. Here, there are a publication, a study about an external validation of this score. When I present you a score, I looking for external validation of the score because they are the performance giving directly by the industry company. But if you want to use score, you need external validation, independent validation. Here's an article published by LASAU, the European Journal of Gastro and Hepato, showing that the SteatoTest compared of biopsy is around an area under the curve around 0.7. It's pretty good for the steatosis, but you can miss some case. So it's good performance, but could be improved. Society biopredictive have also another different, but another combination called the SteatoTest 2. Is the SteatoTest 1 less 2 curves? They remove the BMI because the BMI could be have some variability. For example, aging with people with more age, it's not very, is a variation, it's very complicated to interpret. And also total bilirubin. Why to remove total bilirubin in this score? Because total bilirubin could be depend of both hemolysis with some sample difficult to collect on other pathology, and also pathology have a consequence on total bilirubin, such as the disease of Gilbert. On other hepatic disease could impact total bilirubin measurement. So in the SteatoTest 2, biopredictive remove BMI and total bilirubin. And here, this is an evaluation of SteatoTest 2 compared to SteatoTest 1, and they show there are no lack of performance here. It's good to use the second test, the same performance and the first test, sorry. So the use of SteatoTest 2, it's pretty the same that use SteatoTest 1. So you could measure without BMI of total bilirubin. Another test very used in the literature is the fatty liver index. Here is the total free combination score used. You measure just triglycerides, gamma GT, and waste. And so it's easy to measure, but more complicated to calculate, but this is algorithm calculation on internet to directly put your result and have total result combination scores. So here is they use also the BMI, gamma GT, TG, and waist, and you have a number could define if your patient at a risk to have hepatic steatosis. And as you can see here, in this study with external validation on fatty liver index, you have a good performance with an area under the curve around 0.8 to determine steatosis stage for the patient. So it's pretty good. Remember that the SteatoTest is around 0.7. So here you measure last parameters and it seems better in terms of external validation. So fatty liver index is very used in study about the NAFLD. about the NAFLD. I focus on that. Is not NASH, is NAFLD, simple steatosis. Fatty liver index is not evaluated to determine NASH stage. It's very for simple steatosis NAFLD here. You are also here a third combination score called the Hepatic Steatosis Index. And this time you have the measurement of the aminotransferase, ALAT, and also the BMI. And after that, the states of diabetes, type 2 diabetes, and the sex of the patient. When you are a woman and when you have diabetes, the score increase. So as I say at the beginning, depend the pathophysiology of the NAFLD. When you have diabetes, you increase the risk to have steatosis. And in terms of performance, it's the same as fatty liver index. You have an area under the curve around 0.8, and here is also a test, a free test. You don't have to pay for the algorithm. The formula is here, pretty easier. And when, as you see here in this external validation, more you have a grade of steatosis, more you have an important hepatic steatosis index. So it's a good tool to evaluate the steatosis. To summarize, the mainly used algorithm from steatosis, you have the FLI, the HSI, and SteatoTest, and FLI and HSI is very good in terms of performance to evaluate steatosis of your patient. So it could be better to use these two final tests to evaluate the steatosis. So next, we have the second stage of NAFLD is a NASH with inflammation and steatohepatitis. So in steatosis, we have to focus on the pathophysiology to understand what could be the good biomarker for this stage of NAFLD. So in case of transition on NAFLD to NASH is very misunderstood for those. So this is some leads, is very incomplete. This is just a summary here, but you have the hepatic cells, and these hepatic cells is activated to have inflammation in the liver. So you have both activation of hepatic inflammatory cells by the hepatocyte, but also with between inflammatory hepatic cells and these hepatic cells also recruit blood cells, peripheral blood cells such as neutrophil and lymphocytes, and you have lot of cell into the liver with major inflammation into the liver. But for now, we don't understand all the process regulates this inflammatory. Is still in research, but you have to remember that inflammatory in the liver. So in terms of biomarker, we need to looking for inflammatory in the liver. But this is marker of inflammation and cell activation, so not very specific marker. So for now, in terms of biomarker in combination of NASH, there is no perfect marker, unfortunately. There are some markers, lot of markers in literature, but with all very limited biomarker in combination of biomarker. We talk about combination of biomarker because one perfect biomarker for NASH is impossible, is not exist. So we just use combination of markers. There are 3 markers here used, but is not validated. So it's just for evaluation, global evaluation, but not for the diagnostics. It's not used routinely. But I present you some markers, but not validated by society. The NASH test is a second test proposed by Biopredictive and could evaluate the liver inflammation, the assessment of steatohepatitis. Is the same marker as the SteatoTest. Is the same test here with different calculation algorithm here with the gamma GT, total bilirubin, alpha-2 macrobilirubin, apolipoprotein A1, haptoglobin, glucose, triglyceride, cholesterol. And as you see here in external validation, when you have high levels of NASH test number, you have high levels of histology scores. But the area under the curve here is around 0.7 as a SteatoTest, so you can miss some patients. So the performance is very complicated. Second part, you have the FAST score. The FAST score could be very good here because they are a performance of 0.8, but this is not just biomarkers. This is a combination of biomarker and blood, and also with imaging, with the fibroscan, with liver stiffness measurement or control attenuation parameters. It could be a good compromise to combine imagery and biomarker, but it's very maybe sometimes complicated to have the availability both on biomarker and imagery in some hospital. But it could be good with good performance with 0.8 here, but you need to have also the imagery in your hospital. In terms of research, there are an interesting biomarker combination score developed by a firm called GenFit. It's combined with very good performance here. You will see here 0.8 area under the curve. It could be great in the two different cohorts. And you have here to measure some markers, miRNA, the alpha-2 macroglobulin, YKL40, and the glycate hemoglobin. So it could be good to combine this marker to have a good score for NASH, but unfortunately here it's for research and seems good, but what about the availability of these markers? When you read some publication, you have to know if the marker is available in your lab. For example, in a hospital, we have the glycate hemoglobin, but we don't have these three other markers. It's very complicated and cost to measure. So it could be used, but in specific, very specific laboratory, but very complicated from the screening of general population or in general hospital. So when you read paper with study with new marker or new score, you have to ask, okay, but what is a marker? Can I have the markers in my lab? So don't hesitate to contact your clinical chemist to know if the marker is available in your hospital. So thank you for your attention about this part of focus on simple steatosis and NASH. And in the next session, we focus on biomarker of hepatic fibrosis. Thank you for your attention.